In other words, what happens within that plaque that triggers rupture? Okay? And the major theory that has been undergoing evaluation for the past decade has been some defect of the collagen synthesis within the fibrous cap. In other words, we mentioned that the smooth muscle cells produce collagen that are the major component of that fibrous cap. And in fact, what may predispose a plaque to rupture is a weak or thin fibrous cap due to inadequate production, for instance, of collagen. Okay. Part of plaque formation, and this is something we discussed in class, is the immigration of macrophages. During the proliferative phase of plaque formation, monocytes pass through the endothelium into the plaque, into the tunica intima, and in fact, some of these macrophages begin to ingest or phagocytose the cholesterol that's present, okay, and become foam cells. Now, if inflammation progresses, T lymphocytes also begin to immigrate into the vessel wall. Okay? Now, the T lymphocytes can produce chemical mediators of inflammation, because that's what this is. When we're talking about development of plaques, part of plaque development involves inflammation, the arrival of white blood cells, monocytes, which turn into macrophages, and then T lymphocytes. And these T lymphocytes can then begin to produce molecules such as interferon gamma. Interferon gamma inhibits the ability of these smooth muscle cells to produce collagen. And so, where you have the arrival of a lot of T lymphocytes and the production of interferon gamma, you have limited production of collagen, which results in a weak or thin fibrous cap and increases vulnerability to rupture. Now, in addition to inadequate production of collagen, another biochemical event that can lead to a weak or thin cap is accelerated destruction of the collagen that's been deposited. The article goes on to describe the fact that macrophages produce a protease called matrix metalloprotease, abbreviated MMP, and there are three different forms, MMP1, MMP8, and MMP13, that are capable of cleaving the collagen molecules within the fibrous cap. Okay? And again, with the arrival of T lymphocytes produce a chemical mediator, okay, that can augment production of these proteases and therefore increase destruction of collagen. In other words, it's going to lead to a more vulnerable plaque because the fibrous cap is weaker. The collagen that makes up the cap undergoes destruction. Okay? Now, a second mechanism, okay, for an acute coronary syndrome and thrombus formation, we mentioned is superficial erosion of the endothelium overlying the plaque. In fact, this is a mechanism that's more common in women and accounts for approximately 20 to 25% of fatal cases of MIs. And in the article, they mention several different types of events that could account for endothelial erosion. Okay? For instance, at the bottom of page 2009, it says endothelial cells. That's the simple squamous cells that line the coronary arteries. They're capable of expressing proteases. There's that word again, protease, which is an enzyme that breaks down certain proteins. In this case, it's proteins that tether the endothelial cells to the basement membrane. Okay? And that if these endothelial cells produce a lot of these proteases that then free them from the basement membrane, then the bloodstream is exposed to materials in the basement membrane that trigger the coagulation cascade, that lead to thrombus formation at the site of the plaque. Okay? Now, again, there's some belief that inflammation plays a role in production of these proteases. The article goes on to say that although revascularization procedures, and what do we mean by revascularization procedures? Well, what they're really talking about here is angioplasty and placement of stents. These revascularization procedures that target occlusive lesions in the setting of an acute coronary syndrome, okay? While they relieve anginal symptoms, they get rid of the chest pain, they reestablish blood flow, they abort infarctions. What it says, though, is that these procedures have not consistently reduced the risk of an acute coronary syndrome or death from coronary artery disease. In other words, the same underlying substrate, inflammation, that's caused this particular plaque to rupture hasn't been in any way influenced by that revascularization procedure. And what the article is implying is that same substrate, inflammation, is going to eventually lead to plaque rupture at a different site, predisposing toward a coronary death. Okay? So that, in fact, what they say is that revascularization procedures like angioplasty don't really improve the odds that a patient's going to die from a coronary death any more than medical therapy alone, particularly medical therapy with statins. So they use the word statins a lot in this article. What is a statin? The term statin refers to a lipid-lowering agent that reduces bad cholesterol, LDL cholesterol. The cholesterol that's carried in these LDL packets, okay, is cholesterol that tends to seep into the wall of arteries, including coronary arteries, and contribute to the formation of plaques. And they're saying that aggressive lipid reduction and the use of statins reduces the risk of coronary deaths to the extent, if not more, than procedures. Okay? In fact, at the bottom of page 2010, it says event reduction, which is out of proportion to the shrinkage of the stenoses, has led to the hypothesis that lipid lowering alters qualitative characteristics of atheromata. Atheromata is just atherosclerotic plaques. So somehow that lipid lowering not only shrinks the plaque, but it changes the plaque in some way. Perhaps it stabilizes the plaque, makes it less likely to rupture. Okay? Now, it talks about a comprehensive series of studies in rabbits and mice. Okay? These studies showed that lipid-lowering diets reduce the content of inflammatory cells. In other words, when they treated these rabbits and mice with aggressive lipid lowering, that the amount of inflammation within plaques was significantly reduced. Okay? In addition to reducing the inflammatory content, it says it augmented, which means it increased, interstitial collagen accumulation. In other words, the amount of collagen within a fibrous cap. And it reduced tissue factor. What is tissue factor? Well, tissue factor is a molecule within the plaque which, if exposed to the bloodstream, is going to trigger activation of the coagulation cascade and lead to formation of a thrombus. So that lipid lowering had a lot of benefits in addition to simply reducing the size of the potentially reducing the size of the plaque. It also reduced inflammation and increased collagen formation, and it decreased production of this tissue factor. So what it says is that statins have a stabilizing effect on plaques that extends beyond lipid-lowering action. That besides simply lowering the amount of cholesterol that enters into the plaque, it also these agents also have an effect that is brought about by stabilizing the plaque, that makes the plaque less vulnerable to rupture. Okay? So it says observations in humans support the concept established in animals that lipid lowering can increase the fibrous nature of plaques, a change that should confer resistance to rupture. So, on the last page, finally, it concludes that despite the remarkable benefits of statin therapy, patients treated with this class of agents are still at considerable risk for acute coronary syndromes. Hence the need to make further inroads against this residual burden of disease. And it talks about studies that have targeted other aspects of the lipid profile. In other words, you not only have good cholesterol, you not only have bad cholesterol in the form of LDL cholesterol, but you have good cholesterol in the form of HDL cholesterol. HDL cholesterol is derived from cholesterol that's been removed from plaque. And the theory is that the higher you can get the HDL cholesterol within the bloodstream, the more protective that change is. In other words, if you can elevate HDL cholesterol, that should have a benefit that's equivalent to lowering LDL cholesterol. But so far, studies have not yet demonstrated that to be the case. And it says at the bottom of that page, it says, given the role of inflammation in the pathophysiologic aspects of plaque rupture, several studies are assessing the use of anti-inflammatory therapies. In other words, therapies designed to reduce inflammation, because if you reduce inflammation, then you're going to reduce collagen breakdown, you're going to reduce formation of inflammatory molecules that decrease collagen production, and so you're going to reduce the likelihood of plaque rupture. In fact, one of the trials involves low-dose colchicine. You say, what is colchicine? Well, colchicine is a medicine that's been used for decades to reduce inflammation that's associated with gout. And so the idea is we're looking into various efforts to use anti-inflammatory medication to stabilize the plaque. So maybe the combination of anti-inflammatory medication plus lipid-lowering agents will reduce the overall incidence of not only coronary artery disease, but acute coronary syndromes. In other words, it's going to reduce vulnerability to plaque rupture and therefore unstable angina, subendocardials, and transmural infarcts. Now, I hope that helped with your understanding of this particular article. If not, hey, give me a call, and I'll try to answer your questions. And thanks for visiting. Until next time, can we turn the machine off now? Yeah, turn off. Are we off? Okay.